This meeting is going to be audio and video recorded, and it will be put on the website later on. Can I ask, is there any attendance by reserve members?
So I'm here from Jane Benson, Deputy Lab.
Thank you. And I've received apologies from Dr. Balu and Senel. Okay.
Just to say I'm here on behalf of Carol Furlong, Carol Centre Approaches.
Okay. And can I ask if there's any interest that members of the board want to declare? Okay. The minutes of the meeting, minutes of the meeting from the 22nd of June, are those agreed? Agreed. Public questions, there are no public questions. Petitions, there are no petitions. Deputations, there are no deputations. We then move on to CQC inspection of community nursing.
Yes, so hopefully everyone should have a copy of this in the pack. So I brought with me my colleague Samantha Howard, who's Divisional Director of Nursing and Therapy for CRCH, who is going to support me with the presentation. So firstly, just to recap, so we had in CRCH, just for our community nursing services, in October 19th to the 26th in 2022, CQC visit, which lasted over 3 days, where they focused on what they do now as part of their CQC visits is they focus on just one domain. So they focused on the safe domain for us. And this was following a CLCH inspection that happened in 2021, and they wanted to ensure that improvements that they had suggested at that time had been put into place. And they visited the 2 sites that we work out of in Harrow, so that's Alexander Avenue and Honeypot Lane. And as well as visiting the district nursing services, they also had a discussion with the tissue viability service, the dietary and our rapid response services. So following the inspection, they come back with some recommendations, and they split the recommendations into the should do's, which are things that we have to put into place, and the must do's are the things that we have to put in place, and the should do's, which are recommendations for us to consider. So there were 3 actions which were in the should do's, and they include ensuring that the handovers between the community nursing teams included all the necessary key information, that a formal assessment of patients' capacity was recorded regularly, and to ensure staff reported on any safeguarding concerns to local authority. And then the must-dos, which were obviously the 2 that they needed us to put in place, was to ensure that we had robust processes and systems in place to safely meet the needs of the patients, and to ensure the clinical documentation was completed in sufficient time, detailing all the things that needed to take place that the community nurses needed to do. And I'll just hand over to Sam to pick up.
So just to recap on the must-do actions, the first one was based around, even though the wording is slightly fluffy, it's based actually around staffing. It was under Regulation 18, which was staffing, and then the second one was straight around documentation. So the key work that we undertook, so we reviewed all our processes and procedures. I think a lot of this was already underway when the CQC visited us. It was an improvement programme that we were already on. So we welcomed their visit to really assess sort of where we were then and what we still needed to do. So we created and updated our processes and procedures to ensure that the care that we were providing was safe, effective and consistent. We engaged with other providers to share the learning, and we had a significant engagement with workforce to ensure that the understanding of operational and regulatory requirements was understood by all. We redistributed the caseload between 2 of the teams to ensure that we reduced the travel and increased the capacity of their team for those teams so that they were having more patient-facing time. We upskilled junior staff to provide experience and also to increase the capacity of senior staff to provide more complex care. So we ensured that the right people were undertaking the right tasks. We introduced the clinical triage function, and we entered into an extensive recruitment campaign to try and fill the vacancies, which at that point were around 40% within community nursing. The key outcomes that we've achieved, so we've had a reduction in the clinical vacancy rate. We have a very successful international nurses programme in CLCH, and historically there's been a little bit of reluctance to engage in that within the community nursing programmes, because the international nurses come to us as non-drivers, and obviously, as you appreciate, seeing patients in their homes, and particularly in Harrow, it's quite different in central London. But there are some challenges around public transport and around the capacity that releases for the nurses alongside their travel. But we've had 5 new international nurses that have joined the service to date, and they're actually progressing really well. We established a clinical triage post, and that will address the needs of the patient being referred into the service, so a nurse immediately has sight of that referral as it comes in. To assess the need and to also assess whether the referral is suitable. We redeveloped shadow visits, which was a process of assurance of the patient-facing activity. So a nurse would go out with another nurse and complete some documentation and provide feedback to ensure that the processes that should be followed are being followed and are embedded into their everyday practice. We created 2 fixed-term quality posts, which we put in for a very short period of time. These post holders came in to the end of July, and they were put in as extra help, and actually we did it across Brent Community Nursing because we're seeing similar challenges. And they were put in as an extra quality assurance to introduce and embed the practices and processes that we've introduced. We formalised the daily handover process, and that's been overseen and consistently overseen by managers, which was one of the outcomes that the CQC felt that we could improve on. And the staff survey captured a level of confidence in undertaking mental health capacity assessments. And we're still working on what that training will look like, and the safeguarding concerns and raising those. But that's something that's more trust-wise, and actually, as it's a should-do action, our need to do that quickly isn't as crucial as the must-do actions. So our next steps, we're currently undertaking or having an external audit with our external audit partner of the 2 must-do actions, and that's well underway, expected to be completed within the next couple of weeks. Obviously, we can share the findings of that once we get it. The audit will provide assurance to the Trust Executive Leadership Team whether improvements have been identified and implemented, and if there are any additional areas, improvements or action that are required. We will then create plans for any additional improvements identified. Internal peer review to gain assurance that improvements have been sufficiently embedded into practice has also been undertaken, and we expect the lessons learned and the actions undertaken to be fully embedded by Q3. Questions?
Anyone have any questions? Yeah.
Firstly, can I apologise for my phone being blocked? I'm sorry about that. I thought I'd switched it off. Thank you. So I chair the Children's Safeguarding Partnership, and until fairly recently chaired the Adults Board. We did 2 safeguarding adult reviews last year in Harrow, and in both cases the issues around the proper formal assessment of mental capacity and their recording was sort of widespread across a number of agencies. In fact, CLCH weren't involved in either of those cases because you weren't providing services. Is this something that is sort of being driven throughout the health economy? Because we found it with all our health providers in these 2 cases that the lack of formal assessment and the lack of good recording was a hindrance to sort of having joined up activity.
I think certainly, I mean, I designed a survey just to go out to staff to see how they felt, because what we picked up is that there's almost a fear of doing a mental capacity, well, it's not me, it should be somebody else, I can't do it. Whereas obviously every healthcare professional going in and seeing patients should have the ability to assess capacity. So what we've got to do is do a more supportive programme, and that's what we're doing trust-wide. So it's something we're looking at across the whole of CLCH, because it isn't just Harrow Community Nursing, it isn't just Outer North West, it's all 5 divisions that we've got. And we've just got to have something that's fit for purpose, and that's for all levels of the organisation. It isn't just the very senior staff, it isn't just the very junior staff, it's got to be across the board, and to empower them to be able to make these assessments, or to flag when they feel uncomfortable in doing so that they can get the help that they need.
Yes, I mean, I suppose the follow-up question is, given that the mental health trust providers and the acute trust providers in Harrow in relation to that time period, because there were 2 cases that had exactly the same issues, whether there's any sort of scope for having a joint process to make sure that when you get these complex cases, everybody knows what they're doing. But I mean, that's obviously a more complex issue, because you're speaking for your trust rather than, rather than the joint ones. But it is a, we found it across the piece.
Yeah, that's really useful information, Crystal, as the manager for the partnership in Harrow. And one of the things we've talked about is actually how we do training more jointly, how we do development more jointly when we see an issue across our local system. So I'll absolutely make a note of that and pick that up within our partnership discussions. So I think it could be really useful to the plan.
I'll send you the reviews.
Thank you, thank you.
And I suppose it's worth adding, we're involved from our division, it isn't a Harrow patient, but we're involved in an external SI, serious incident investigation, from a partner organisation in another borough. And actually what we're seeing immediately, and this is mental health services, it's our community services, it's GP, it's a cross-border patient, and we find that we have some significant challenges where the GP's in one borough and the patient's resident in another. But actually what we can see immediately in the serious incident, and it's actually a psychiatrist from Broadmoor that's chairing the panel, and is that the communication across multiple organisations with this patient at the centre actually has been a real challenge. And I don't think that's unique to that end of our division. I think it's probably the same across all borders, across all organisations, and it is how we can work better to ensure that we all jointly meet the needs of the patients, regardless of how many services are involved.
That was interesting. I'm asking a question as a lay person, not someone in this field. So you mentioned the introduction of clinical triage function. Is that so? I mean, how does that work? Because this is community here in that sense. Is it always done face to face with patients, or is there a remote? Is that how it's done?
So,
and what have been the actual benefits?
When the referrals come in, they obviously come into a single point of access. It's what we call SPA, and non-clinical staff put the referrals onto the system. What we then need is for a clinician to look at the referral to see really whether it's appropriate. We do have a number of referrals that are inappropriate that may be for non-housebound patients that are asking for district nursing services, and therefore we need to ensure that the referrals are appropriate for the services that we offer. So having a clinician at that point will absolutely give you that. They may phone the patient and the family to check out some more details. They may go back to the GP if that's where the referrals come from to check out more details. But it's just to ensure that the right patients are on the caseload and that they're seen within the appropriate period of time, because obviously some are seen within 24 hours, others are seen within a week, depending on the service that they've come in for and what they've come in to be seen for.
So it's more efficient.
Yeah.
The right frequency anyway. Then I've got another question. It's going to be an internal peer review to gain assurance that improvements are sufficiently embedded into practice, and that's pretty key. So internal. So who will actually do that? So is it all the team just giving their input, and can you be absolutely confident that it's going to give an objective view of what's actually going on?
So that was actually done prior to our external auditors coming in. Right. So that we could just check that we were fairly confident as a division that we've done what we said we were going to do. The external auditors have come in with obviously a fine-tooth comb, and we've got pages and pages of lists of requirements, still, even though we spent a number of hours with them face-to-face last week. So the internal peer review had already happened, and it happened from the Quality and Learning Division, which is a separate division from us as a geographical
It's
division.
under next steps.
Yeah, so when this was, these papers have been in for quite a long time, yeah.
Yeah, thank you very much for that report. Clearly, a lot of work has been done to work behind the scenes to sort of address the improvements identified. My question is, firstly, the improvements regarding the clinical documentation. I don't get a sense of what the extent of the problem is from the report. Are you able to divulge, how many, what we're talking about? Is it per patient documentation, or is there a significant amount across various areas? There is a lack of documentation. I just want to get a sense of feel as to what the extent of the problem is there. And my second question is, what is the current vacancy rate for staff?
So the documentation, what the CQC found is that there were inconsistencies. So they found that obviously the patient records are made per patient at the end of the visits, and that there wasn't any or there was a lack of consistency around what people were recording. Some people were recording something very brief, some people were recording something very extensive, and actually what they wanted to see was the processes behind that, and how people document in the same way, using the same assessment processes, so that you could look at two patients and know actually about them and the important things. So there's a lot of work gone into that. And the second question, vacancy rates, I don't have it at my fingertips.
I think approximately it's about 30% now, so it has improved, not as quickly as we would like, but I think everyone knows there's a national shortage of nursing staff anyway, so hence why we're doing a lot of the international recruitment. I think the areas that we have improved through recruitment as well as our leadership. So we had some gaps around what is classed as our band 7 level, which is our sort of senior sister type level in the community, and we've actually recruited to those levels, which I think is a really good thing, because once you get your leadership in and you can show that the improvements are happening, then you often find people will bring people from other areas into working, and actually we've seen that play out where we've had staff bringing staff from other areas into working in the community.
And just back to the documentation, the two new post holders that we put in, they've just developed something really simple that's in a nurse's pocket, but it gives them all the assessment processes, the templates, so that because EMIS, our clinical system, the templates are quite complex, and this was just a very quick sort of go-to, just holistic assessments, wound evaluations, insulin administration, wound photography, just so they can pop it in their pocket, and the feedback from this has been really positive. So they've all got them in place.
Thank you very much.
Is there any more questions or comments? No? Okay, so okay. So the recommendations on page 15 were basically just asked to note the report and to provide feedback, which they've done. So thank you very much. Item 8, the health and wellbeing strategy update on the basis.
Thanks, Chair. Good morning, everyone. So I'm going to do a brief introduction and hand over to colleagues who are going to do run through 3 short presentations. So we know there are many factors that determine a person's health and ultimately the health of our communities in Harrow. We regard these factors as the building blocks of good health, as well as education, housing, our social networks. It also includes our surrounding environment, clean air and access to green spaces, the economic prosperity of the borough and local communities, meaning jobs and economic development, and our communities themselves and the assets within them and the access we have to them. So this report and presentation is split into 3 areas and sets out the work and commitments being taken forward as part of the healthy place domain of the health and wellbeing strategy. This includes climate and nature sustainability and the consultation that's out for at the moment, economic development and culture and leisure. And they're being presented here because of their links with the impact on the health and wellbeing of our residents and communities. We're going to start with economic development and then move on to culture and leisure and then nature and sustainability. And I suggest that we pause after each short presentation just for any feedback, because I know especially the climate and sustainability strategy is currently out for consultations. I know Matthew and team are quite keen for a bit of feedback on that. So I'll hand over to Mavis, who's on the screen.
Thank you. Morning, everyone. So I'm just going to do a very short presentation on our economic strategy. So Harrow adapted a strategy in July, just a few months ago. So some of you may not have seen it yet or had a chance to familiarise yourself. So I'm going to give you a quick sort of tour around the strategy, the key elements of it, what we're hoping to achieve, and give you a snapshot of some of the objectives and targets within the strategy, which, as Seb mentioned, links in well with the health and wellbeing strategy, and particularly around the social economic impacts that have on people's health. And I think within the health and wellbeing strategy, it's at 50%, which is a significant amount. So let me just share the presentation. Great. Can you all see this?
Yeah, that's up.
Great. Perfect. So just a bit of an introduction. The health, so the economic strategy is 2023 to 2026. So we're looking at what we can achieve over the next 3 years. It closely aligns with the council's vision of restoring pride in Harrow, and we've also looked at how it aligns with our corporate priorities of being a council that puts our residents first, being a borough that is clean and safe, and a place where those in need are supported. The economic strategy is split into 3 priority areas or themes, if you like. So the first one is skills and employability, and this is about supporting and empowering our residents to boost their life chances. This aligns with our priority of being a place where those in need are supported. The second priority is business growth and job creation, which is about encouraging a thriving economy to support local businesses and creating local jobs. This aligns with 2 of our priorities, which is a borough that is clean and safe and a place where those in need are supported. And the third priority is high streets. So restoring pride in Harrow's high streets by improving public realm and creating cleaner and safer environment. And this aligns with being a borough that's clean and safe and a borough and a council that puts our residents first. The economic strategy is evidence-based. So just to give you a bit of insight into where we got our sort of baseline data to then build on the strategy and what we want to achieve. So we looked at the demographics of our population. So recently we've had the release of a lot of the census information. So we've used that to sort of give a picture of the borough and how best we can support our residents and communities. So if you look at our education level, for example, it's fantastic that Harrow is in the top 10 within the UK of residents that have the highest qualification, which is level 4 and above. So that's at 45% of our residents have a qualification of level 4 and above, which is fantastic and puts us in the top 10 in the UK. However, on the flip side, we have 17.4% of residents that noted on their census return that they had no qualifications at all. This means that we have a high percentage of, and we also have a high percentage of residents that only have a level 1 or level 2 qualification compared to London as an average. So there is some work to do there. Business community. So we've done some research into our growth sectors within Harrow and how we can provide support to those sectors to stay in Harrow and to create jobs in Harrow, so creating those local jobs. We've looked at a number of businesses that employ more than 100 people. So at the moment, that's 102 businesses. We've looked at the sort of contribution of our top 3 private sector employers. They provide just over 6,000 jobs. For high streets, we look at vacancy rates in the town centre and district centre. So those are things that we're hoping to improve. So we don't want to have a lot of vacant shops within the borough. We want to bring them up to use, create jobs, create spend and dwell time, particularly within our town centre. And of course, the cost of living has had a significant impact on a lot of our residents and communities. So within the strategy, we talk about this and the steps that the council and our partners have taken and are still taking to address this, and also the funding sources that we recently received. So, for example, from the UK Shared Prosperity Fund, which is a replacement of the previous EU funding from the government. So there's a number of projects that's been developed to support and address with the cost of living. The next few slides are just going to be a really quick snapshot into each of the themes and what the KPIs are that we're measuring, the type of partners we're working with, and the objectives that we're hoping to achieve. So for the skills and employability, for example, one of our key objectives is to support stakeholders, small and medium-sized enterprises, and the local sectors to provide apprenticeships and training opportunities, utilising the apprenticeship levy to ensure uptake in key sectors. There you can see some of the key partners that we're working with, such as our business forum members, traders groups, HA1 Bid, Voluntary Action Harrow Co-op and West London Business. Another objective is around supporting our residents to secure jobs created through our Harrow Strategic Development Partnership and other construction programmes, working with the colleges, youth groups, Job Centre, Waits, Young Harrow Foundation. In terms of the KPIs, so these are the measurables. Within the strategy, we're going to be measuring things like the number of apprenticeships in the borough. So if you're interested in that, you can sort of see where our baseline is. So we're looking back for the apprenticeships, 2021, 2022, where Harrow was compared with London, for example, and our target by 2026 is to match or exceed the London performance. So this is something that's going to be tracked on for this particular indicator on an annual basis, because that's how often the data is released. And we're also looking at qualifications at level 3 and above. So looking at how many residents have that qualification and how we can support to improve that percentage. So again, it's that partnership working. This isn't something that's solely within the council's control. It requires partnership working, hence why we work closely with Stanmore College, Harrow College and other providers. And we also have the Learn Harrow skills provider, skills offer as well. So they provide training and skills to residents within Harrow. So those are all the sort of various partners and initiatives that will help us to achieve some of these targets within the strategy. So just moving on to business growth and job creation. So one of our key targets is to encourage business startup growth through providing outreach and business support, access to new equipment, networking events through the delivery of the UK SBF, so that's the UK Shared Prosperity Fund, and linking into other business engagement services. And as far as possible, the support that we offer will be differentiated to meet the needs of the business, varied ambitions and points within their growth cycle, because Harrow has got a lot of SMEs within the borough, so we also need to tailor the support depending on what the business needs and what they're hoping to achieve in terms of growing. Key stakeholders are listed there. I won't run through them all. And another objectives is we want to promote the delivery of events like Meet the Buyer, so providing more supply chain opportunities to our local businesses, and business to business mentoring for tier 1 and tier 2 suppliers as well. We will be measuring business births and deaths. So we look at the survival rates of businesses. So once they open up, how many of them are surviving beyond 5 years within Harrow? So as you can see, as of November 2022 for that year, only 40.4% of our businesses were surviving after 5 years. However, this is higher than the London average. So obviously it shows that we're just above the trend of 38.8%, and our target is to remain above the London average. And we're also looking at digital connectivity. So we're going to be tracking the rollout of the full fibre availability in Harrow and compare it with London, and ideally be on par with London, reduce that differential between our borough and the London average in terms of that rollout, because being digitally connected, particularly for businesses, is important, and also for residents that want to apply for jobs. A lot of applications are online and require some level of digital skills and access to digital equipment. And then the high streets priority. So this is an overview of the objectives within there. So for high streets, we're looking at creating a cleaner, safer and more sustainable district centres and high streets. We want to encourage more sustainable shopping, include electric vehicle charging and improve green infrastructure. Partners that we'll be working with are, of course, local businesses and the Greater London Authority, who provide a lot of funding around these initiatives, and also build on our arts and culture infrastructure, facilitate and deliver more cultural events in partnership with stakeholders to animate public spaces and increase dwell time, and working with the Cultural Forum, District Centre Partnerships and HA1 Bid. the indicators that we're going to be measuring under this theme are the vacancy rates. So looking at the high street vacancy rates in the town centre and district centre at the moment. At the time of the baseline, so when we took the baseline for 2022, it was at 4.57%. I had a recent update from a colleague earlier this week, and we're now at 3.93%, which means there is a slow reduction in the vacancy rate in our town and district centres, which is good news. And our target is to remain below that 4% up to 2026. And of course, we're also measuring our footfall within the town centre area. So at the moment, we've got cameras that can sort of measure our footfall count within the town centre. So that's something we're hoping that to see improve on an annual basis as well. And a sort of full theme within our strategy is our partnership working. We can't deliver any of these objectives or try and influence the performance against those measurable KPIs on our own in terms of the council or the borough on its own. We need to work externally with our partners. So within the strategy, you will hear a bit more about how we do that. The various groups that we've set up. So we've got the Economic Strategy Steering Group, which is made up of all those partners that I've previously mentioned. We've also got a subgroup, a working group, which focuses on Harrow education and jobs specifically. So we sort of look at those opportunities there. There's a business forum, there's a borough-wide traders group. So we've listed all of the traders groups there, and I think there's a few more that's been developed since the strategy was published. We've also got a Woolstone advisory group and Learn Harrow advisory board. So again, that sort of partnership working is key for us to achieve what we're hoping to within our economic strategy. And if you look at the commitments that are set out within the Healthy Place part of the health and wellbeing strategy, you will see how it closely aligns with the objectives that we've set up within the economic strategy. So that's the end of my presentation. I don't know if you want to ask questions now or save it for later.
Thank you. Any questions on that presentation? I can't see any hands, so Simon.
Yeah, thank you for a comprehensive presentation. Really interesting. My question related to when you're talking about recruitment and development of employability in the borough. So certainly, whilst technically Norfolk Park doesn't sit in the borough, it's right on the borough. And I don't know if our stats appear at all, because we're 8,500 employees. At least, I don't know what the split is on our site, but at least half of those will be on the Norfolk Park site. So for me, that there is something more we probably can do in terms of access to employment, the apprenticeship stuff, the training levies and the use of those. We do some work with Harrow College around project search, and that's been really successful in terms of youngsters with a disability and bringing them into employment. But we don't do probably enough on a large enough scale, and as part of our objectives around the NHS sort of core 20 plus 5, we do want to reach out more, I think, in terms of attracting local people into our services, but I'm not sure that we do enough between ourselves in terms of what that structure, what that process is, and how we can link out to schools perhaps more in terms of health, the different types of health careers. It's not just all nurses and doctors. There's many other roles within hospitals, etc. So I'd be more than interested outside of here discussing what we might be able to do and how we could work together on more of that agenda. It's a target for us, and it's clearly a target for the council, but we just need to join up really.
Great, absolutely. I will contact you outside of the meeting, Simon. And we do have a job fair that's coming up in October, which is led by our Excite team, who manage our job brokerage and apprenticeship programme. So I will drop you an email. Thank you.
Right. Thanks, Mavis.
Lisa.
Just to really build on Simon's comments, I think probably across our NHS workforce, so within our community providers, social care providers as well, it would be really useful to tie all of that together. And of course, primary care probably struggle a bit more as sort of much smaller businesses, 32 practices in Harrow. How do they come together around apprenticeships and really promoting careers in primary care, which again are much more diverse now than traditional nursing and doctor careers. So would also be interested being part of that conversation, how we could look at that wide health and care workforce. And just another thought as well of thinking how we link health and wellbeing strategy to economic strategy, and some of the initiatives that we're exploring. I'm thinking within the carers agenda of how we create carer-friendly workplaces, how we might work with local businesses around their policies there, as well as thinking about an opportunity to deliver proactive health reach through our local businesses too, acknowledging our SME sort of makeup in Harrow makes it slightly more complicated than I know Brent do a lot of work in factories and manufacturing, but I think it would be really worth exploring how to really enhance that work setting as healthy place as well.
Absolutely. Another event that's happening next week is Harrow Means Business, which brings together a lot of our local businesses. There'll be a number of local businesses exhibiting as well as attending. So again, I'll be happy to share that information with you, but definitely do need to have a follow-up conversation just so we can link in a bit more, and maybe joining our steering group could be a starting point for the both of you.
So I think Lisa just stole what I was going to say, which was actually I'd be really interested as well being involved from a CLCH perspective. So actually, rather than you repeating it 3 times, I wonder if it's worth you just getting the 3 of us in the room together to talk through. And I'd be very interested in when you were saying you had the work there. Actually, it'd be really interesting for us to have a stand there as well, from an NHS perspective.
Sure, I'll link you with the Excite team. Of course, I don't give out the tables or stalls, but it shouldn't be a problem. So I can't see everyone's full name. So Seb, if I ask you for the contact information for everyone, and then I will send out an email and maybe we can set up a meeting.
Lisa, do you want to take sort of you just send the details of the
Yes.
Yeah, thank you. Thank you very much for the presentation. I think it's quite clear that a lot of us are doing this work. So I know primary care leads are already engaged with apprenticeships, but I think we are all having these silo conversations with the council. So I think there is a need for us to join up these conversations and have a much more strategic approach as to how we approach these and not draw on, any one partner resources. I think, Jackie, we are part of that work there that's coming up. So again, it's about how we communicate what's happening and have a much more coordinated approach to some of these offerings in the council.
Thanks, everyone.
I guess just to support everything that's been said, and I think at North West London level, there are lots of conversations happening around anchor institutions. That's not necessarily, I think, coming down into the boroughs. So I think this is a really good opportunity to start that actually, through a number of individuals around the table already saying, yes, let's meet up and have a chat. So if we can maybe think about that group and actually think about what that might want to do in terms of some of the local work.
Yeah, thank you, Paul. As the portfolio holder for business and employment, I just wanted to say this sounds wonderful. It's it's very useful to get a meeting where we actually are all come together and drive this forward. So huge opportunity, I think.
Thanks, everyone. We now move on, I think, to the next bit of the strategy, which is the change. Matthew, are you doing this?
I think we're going to hear from Tim first on the
Culture and leisure first,
just
Tim, who's also online.
Good morning, everybody. I hope you can hear me okay. I've just got a few slides to show, to give a brief overview of culture and leisure in Harrow and how that supports mental and health, mental and physical well-being. So I hope you can see that okay. Yeah, great, thanks. So Culture and Leisure Services deliver a range of activities that support mental and physical well-being, and I'll go into a little bit more detail on the various areas in due course. Obviously, it will be a bit of a snapshot and a brief overview of the the various activities and services that are provided. Council has a major role within the borough of providing affordable sporting opportunities. It's a direct provider of sort of entry-level facilities, which is obviously really important in terms of getting all of the community as active as possible. And those are either free, things like the outdoor gyms that pretty much all of the parks in Harrow have now, or things like free swimming for those aged 65 plus, which I'll come on to a bit more in due course. And also sort of pay and play activities such as the grass pitches in parks and also the tennis courts. Again, hopefully it's quite sort of reasonable and affordable levels. Just also to mention that currently in the process of developing a new indoor and outdoor sports facility strategy, which will cover the period 2023 to 2037. Obviously, it would need to be updated regularly during that period. So the aims of that strategy is to improve health and well-being and reduce health inequalities by increasing participation in sport and physical activity in the borough, and also as part of that ensuring that facilities are of the appropriate quality and are available and accessible. It provides an evidence base and clear priorities for improving present provision and supporting justification for new provision, which is obviously really important in terms of making that case for new provision or improvements. Informing the most efficient management and maintenance of playing pitch provision, and the development of an action plan and a list of key priorities for the sort of short, medium and longer term. Just a little bit more detail on the strategy. So in terms of the outdoor facilities, the playing pitch strategy, as it's also known, what's been identified from the work that's gone into developing the strategy to date is that there is significant demand on existing grass pitches in the borough, particularly for cricket and football. There is a definite issue in terms of the quality of those grass pitches. For quite a high percentage, about 40% of the grass pitches are considered not to be of good quality. In terms of the indoor facilities, particularly around key facilities such as swimming pools and sports halls. Swimming pools, there's a lot of current demand is met from facilities that are just outside of Harrow, in say particularly the London Borough of Ealing and also Hillingdon, and obviously that just depends on where people live. So to a large extent, demand is being met from both in borough and out external borough facilities, but there is a need identified to either modernise or replace existing swimming pools. Sports halls, again, like most of London, demand basically exceeds the number of facilities available, but that is common across London. But again, there is a need to sort of improve ageing facilities. So one of the key things to be progressed and decisions made on in the future is around Hatch End Swimming Pool and Harrow Leisure Centre, the council's two main sports facilities in the borough, which are both ageing facilities. In terms of the leisure centre, so the leisure centre's had over 1 million visits in 22-23, and you can see that compares well with the previous year as we've come out of the pandemic, but hopefully gives an indication of how well used those facilities are. And in terms of specific activities to increase participation, there's the exercise on referral programme. There's the free swimming I mentioned for 65 plus, and also reduced swimming prices for those aged 60 to 64. There's the leisure card that's available for for a very small charge for those who are 60 plus students, people with disabilities and those on low income, and that enables people to get 20% discount on specific activities. There is also a residence leisure card, which is slightly more expensive, but again, discounts on certain activities. The Harrow Leisure Centre is home to Harrow Kingfisher Swimming Club, which is a club that teaches people with disabilities to swim, and they get discounted pool rates at the leisure centre. And very recently, we've had a new Changing Places toilet installed, which was opened last month. So obviously a fully accessible facility, which will help to make the leisure centre more accessible for everybody. In terms of on the cultural side, so our key facilities are Harrow Arts Centre and Headstone Manor and Museum. There were over 230,000 visits to both of those facilities in 22-23. Just identifying a few key, obviously there's a big range of activities that happen on a regular basis at both of those sites, but just identifying a few key activities and programs. So there's the Young Creatives program, which is government funded via Learn Harrow, Harrow's adult education service, and that program, which has been very successful, aims to encourage young adults to develop their skills and understanding of the arts industry. There's also been a range of workshop and events delivered through the link up with Learn Harrow, including things like 6-week swim dance courses for adults, mask making for families with special educational needs. We've recently opened the new Greenhill building at Harrow Arts Centre, which is a great new facility that will enable more space basically for a range of workshops and multi-art spaces. There's already been a lot of interest from dance groups to use the new spaces. So that facility was partly GLA funded. So all of these cultural activities provide opportunities for people, for the community, a whole range of residents to improve their mental and physical well-being. Yeah, so that was the slides that I had.
Thanks, Tim. Does anyone have any questions or comments on that? I would just add that one of the real challenges for us in the next sort of 5-10 years is the replacement of the leisure centre and swimming pool. I think actually across London you get the end of life of a lot of these facilities that were built in the 70s or 80s, and we're now struggling to work out where we get the capital to fund them. But in terms of health and well-being, having those facilities is so important to prevent a lot of the problems that if we don't prevent will come at all of us with a huge issues rather than having more healthy lifestyle. Is there any questions?
Just to reflect a similar sentiment, I mean, I think about how we manage diabetes care, for example, in Harrow, and having some of the highest rates in the country, and putting a lot of work into the primary prevention, how we're managing the community, avoiding hospital admissions, but actually to shift from that position of having some of the highest rates in the country is prevention, and this is so critical, this work to it. And I guess some of my thinking was, are we sufficiently tied up on some of the data and the intelligence that we have around particular populations, age groups, areas of Harrow that are where we're seeing real rise in some of our long-term conditions rates, and how we might feed that into a sports and leisure strategy, and would be really keen to work with anyone on how we might bring some of that intelligence together.
I think, I think from my point of view, it'd be helpful to have a conversation with you, Tim, and Mark Billington, because if we start to get bids for various grant funding for these things, to have a strong health case that sits behind, it would be very helpful to us to kind of show the government and other funders that there is a good reason to do this. So I think that'd be really helpful.
A couple of years ago, it might have been a bit longer, we got very excited about the Golden Mile in primary schools in particular. We had a couple of presentations at this about the Golden Mile. It came on the agenda, but it seems to have faded away. Is there still any life left in it, or is that not on the agenda anymore?
Can someone explain to me what it is?
The Golden Mile. It's originated in Edinburgh in a particularly difficult sort of urban setting for a school, where the head teacher, who was a keen runner, decided they were going to take all their pupils for a mile run before the school started. And that improved sort of health, concentration, academic, improved everything, right? And it's free, of course. Well, nothing in life is free, but seems to be sort of without cost. Anyway, it's spread across the country, and we had a couple of sessions at the Health and Wellbeing Board, I don't know, 2 or 3 years ago, where we were training up schools and there we go. Just wonder what's happened to it.
Yeah, I'm happy to come in there. So that's still certainly on the agenda. So we have a Healthy Schools London programme, and we have a public health officer that supports that programme of work. And the schools get awarded bronze, silver, gold status based on a framework in terms of what they're doing within their schools, from having asthma-friendly settings to water-only provision to doing the daily miles, especially in those primary school settings. So, and that's reported as part of our performance reporting. And I mean, if the board wants to hear more about that, we could always come back at a later date and report back on the metrics, how many schools are doing this, because we do capture all that information.
Yes, because we got excited about it. There was quite a lot of sort of structural energy, and then it took a while for the schools to actually adopt that which we were very keen on and about which we were doing sort of planning and preparation. So yeah, I mean, it strikes us as a complete win, really, if the schools are doing it. It's good for children and good for everything, and it's cheap-ish.
Just to sort of emphasise, really, I mean, a lot of what you described, Tim, a lot of that is supported by lots of voluntary organisations in the borough.
Yeah.
A lot of it is done by volunteers. I think it'd be good to recognise that, but also to think how that's nurtured, as it were. Because it has a double sort of win-win, really. So people that are volunteering on leisure activities are also benefiting in terms of their own health and well-being and mental health. So I think it would be good to recognise that in the strategy, but also to think about how that can be nurtured and built upon, because I think it's a local strength, really.
Yeah, thank you, yeah.
I don't see any other hands. Matthew, are you now going to do?
Yes.
Technically, we've got 4 minutes left of this.
All right. Okay, that might be a bit of a tough ask on this topic, but I'll keep it as concise as I can. Let me just give me the slides there. So, good morning, everybody. Nice to meet some of you who I haven't met before. I'm Matthew Adams. I'm the Assistant Director in the PLACE team for climate change and energy. The operational area is energy, but I've got an overview of the climate work generally. And what I wanted to do today, if possible, is give you an overview of the climate and nature strategy that's currently under consultation, and talk a little bit about the consultation, a bit of the data for Harrow, just so you've got a little bit of context. I've only got one slide on data, so I won't bore you too much with that. A little bit about what the council's been doing in the 4 main areas of the strategy, which I'll talk through. And most importantly, really, to get your input, if we can, at the end, about what our partner organisations are doing in this area around climate change, carbon reduction, nature, and what opportunities there might be to join up. And of course, we can always bring this back to a later date if people want to take it away and have a think and bring it back. So I won't go too much into the whys and wherefores of climate change, but I mean, you'll be well aware our climate is changing quite rapidly, and we're really just at the beginning of this period of significant change. That little diagram on the bottom there, number 6 on that list, that's the 40 degrees days last year was Northolt. Number 5 is Kew Gardens, and number 3 is Heathrow. So you can see there was a big West London. It was one of the hottest places in London last year. We've just come out of the hottest June, hottest records since September, since 1911, I think. And it's not just the heat, it's the impact on ecosystems. So that's why we've called it a climate and nature strategy, because really want to make it clear this isn't just about carbon, this is about its impact on all the things we depend upon for clean air, for food, massive part of obviously the ecosystem support that we get. For medicines, many of our medicines, R&D comes from the natural world. So it's all bound up, and that's why we've sort of couched it in those terms. This is my data slide, so it's very small if you look at the back of the room, but just to talk through the colours really. This is a bit of work we got showing the average carbon footprint of a Harrow resident. And it's clearly an average. People will go up and down depending on their lifestyles. And the point I've made first of all is it's very linked to socioeconomic status. So what we find in London is that the poorer boroughs generally have the residents have a lower footprint. They have smaller houses, maybe they don't drive, they don't fly as much, they don't eat out as much, all those things which contribute to carbon emissions. But the headline really is that the blue segment, the third of the emissions, and it's about 8 tonnes per person in Harrow per year. And I'll show you a diagram showing what a tonne of carbon looks like in a moment. The blue section, about a third, is house and home, and it's the power that we use in our buildings, and gas, mainly gas heating. That's a big constituent of the energy use in our homes. The red, sorry, I beg your pardon. That's transport. I beg your pardon. The red one is the second third is the housing. The transport one is both our emissions in borough, so vehicles we use in the borough, but it's also things like our flights and our travel out of borough. This research is good because it captures the whole footprint, not just what's happening in Harrow, but the impact of the people living in Harrow, even if the emissions are elsewhere. And then the sort of last third, all the rainbow-coloured segments, is all the other emissions associated with our consumption. The biggest and probably the most important of which is food. And food is a really important part of most people's carbon footprint. Probably the biggest single thing anybody can do in this room, myself or anybody else, it is to think about eating more climate-friendly diet in terms of their emissions. That is a huge part of it. So you can see that focus on energy, on transport, on our consumption. And when we came to design our climate strategy, we really looked at these sort of 4 main themes and tried to keep it simple, but it really covers the full gamut of things that would make a more sustainable future. So clean energy used efficiently. All of these have, I hasten to add, many health and well-being links. So clean energy used efficiently is about moving away from fossil fuels for our heat and power. Practically, it's things like heat pumps in our homes and buildings, corporate buildings, hospitals, health settings, etc., to reduce our gas reliance, and also generating renewable energy, which in London is really solar. Lots of wind, of course, elsewhere, but in London mainly focusing on solar, and making our buildings more efficient. And close links there to health and well-being outcomes around healthy homes, removing damp, particularly the vulnerable. Theme 2 is green mobility. So this is the transport theme. Really, how can we, for Harrow's purposes, reduce our reliance on fossil fuel vehicles in the borough? So electrification is a key part of this, but it's also about active lifestyles and making our borough more amenable to transport by cycling and by foot. The third theme is called a waste-free economy, and this is really all the other bits around our consumption. So, the computer we've got here, the clothes we're wearing, the food we eat, all has a footprint associated with our consumption. And many of you might have heard of the circular economy, and what we really need to do is re-gear our economy so we start to make better use of the resources that we take from the planet, keep them in circulation for as long as possible, and then fully recycle them at the end of use. And in healthcare settings, I imagine this is a big part of what the NHS does. Is looking at doing. Obviously, there are huge supply chains in the NHS and councils as well. So how do we influence our supply chains to change? And then the last theme, because we didn't want to forget it, it's so crucial, is about how we can make space for nature in our borough. And there's 2 bits. It's around mental health and well-being, access to open space, nature, the recreation we just heard about, and sports. But it's also about resilience. So it's about resilience to climate change. So some of the things we would look at in that theme around tree planting, around use of open space, flood alleviation, droughts, all of these things that are coming our way that we need to try and make the borough as resilient as possible to deal with. So as I said, although we talk about carbon, and that really is the sort of measure we've got, many co-benefits, clean air, improved public health, resilient communities, innovation and green growth, big links to the economic strategy and different ways of doing business, a thriving local environment we can be proud of, and ultimately, of course, about protecting future generations of Harrow residents from the worst of climate change. So just a few examples of what we've done to give you sort of feel for what action we're taking in these areas. This is the top left photo is Harrow Arts Centre. So we've installed a range of solar panels there, but importantly also we've replaced or supplemented all the heating with heat pumps. So Elliot Hall, if you know it, the big sort of Victorian ex-school building is now powered 90% by heat pumps for its heat use, and a number of the smaller buildings as well. And on this very building, that bottom right photo is a solar array we've literally just installed. It's the biggest in Harrow, equivalent to about 30 houses worth of power we're generating from that. And it costs us £150,000 or thereabouts, but it's expected to save at least £40,000 a year in electricity. So you can see with electricity prices going up, these things start to make real economic sense, as well as saving the carbon. And that's a tonne of CO2, so you can visualise it. Sphere 10 metres by 10 metres. So the Arts Centre project is saving around 50 of those. But remember, every person in Harrow is letting go of 8 of those buildings every year. So we've got a long way to go, but it does sort of bring home the level of the journey we're on. Green mobility, we've got 16 electric vans. I'm sure other businesses and organisations in Harrow are also looking at how they can electrify their fleet. This is our electric sweeper we've got, which we've trialled and has been very successful, quieter and battery life is fine. It's an example, I think, of how you can sort of incrementally introduce a technology and get confidence in it. But it's not the whole story. There's other things we're doing, of course, around school streets for children, closing the school at pick-up and drop-off time, and seeing how that can encourage active travel to and from school. We've got a programme this year for 200 electric charge points on street lamps as well, so residents can start to think about make it more accessible to transfer to electric and hybrid vehicles. Another thing we've done, which is relevant, I think, probably for everybody in this room as well, is introduced a formal policy charter and toolkit around testing carbon in our supply chain. So when we procure new contracts, we now have a formal requirement that we will ask questions of our suppliers. What are you doing to reduce your carbon emissions and impact on the environment? And we're measuring that to a minimum of 5% of the total marks, can be higher in some contracts. And the great thing about that is it was a joint project. Harrow led it, but we got 7 other London boroughs plus West London Waste to partake in it. So we're all asking these questions. Really positive. I think many suppliers wanted to show their sustainability credentials, but of course we weren't really testing them on that. So this is a great opportunity for those conversations about how we can do things differently. And just a quick one on the healthy places, that this is an example of one of our parks, Kenton Recreation Ground, which is just next door. And this was on one of those hottest days, those 40 degree days last year. And you can see that we'd mown the regular park on the right, and it was unfortunately a bit of a desert. On the left, the same day, that was an orchard area that was left to grow longer. And yeah, it was buzzing with life that day. The other side was sort of bleached and so it looked like it was pretty much dead, really, biologically or ecologically. So there are things we can all do, I think, in doing things differently to use our public space better, and of course make it a more attractive place and a better place for people to spend time in. And then lastly, also just to link to what Tim said about community events, we've also been working with our events team. Plastic Ocean was an excellent thing that was done last year by the Harrow Arts Centre, which was an interactive thing for children where they could go in, had a performance inside a whale, and it was about plastic in the ocean, and I think it culminated in saving the whale, which was always a good outcome. And I think we shouldn't underestimate the sort of power of these experiential things to really influence people's attitudes to things. We actually have a school eco conference coming up on Friday, which is being hosted for primary schools by West Lodge. So building that momentum in our schools and young people, absolutely crucial. So I mentioned consultation. We've got it online at the moment on the My Harrow Talk website. I think Nomza, sorry, I should introduce my colleague Nomza, who's our climate programme officer. Nomza will post it in the chat, so you've got the link. It's open to the 24th. We'd really love your input in any business and resident surveys there. Please promote it through your network for the last couple of weeks. We've got a number of, we've been running all summer. It's been on the website and through Harrow online and all the other things we've got. So, but if there's things you'd like to add, this is a really good way to input. And we've also got an interactive map on there. So if you're doing things in your organisation that relate to any of the things we've talked about, nature or energy or waste or green transport, we just want to hear about what they are and put them up, and we can promote that. So that's probably enough talking, but from me anyway. What I thought would be useful is just some open question really. What action is your organisation involved in on any of those 4 thematic areas? And secondly, are there sort of any opportunities that you see to work together with us, with each other, to scale this action and how?
Thanks, Matthew. Does anyone have any comments or questions or answers to those questions?
So I think it might be worth us putting you in touch with, we have a green lead
Sure,
for
okay.
the organisation, who is obviously driving stuff through the CRCH around the cars we use, etc. Because obviously the community service, we use a lot of cars.
Yeah.
So I think if I put you in touch with
that'd be great.
maybe you can talk through what we're doing.
I expect a lot of commonality in the challenges as well, costs and all of that, but that'd be great. Yeah.
Okay.
Simon.
Yes, so similar really, and as you're speaking, I was thinking that within a council, you've probably got a level of expertise that we might not necessarily have within the trust. So there's a number of things that we're doing, and we did a part of our heating system, replace that with a combined heat and power unit and that kind of thing. And there was SAILEX grants from the NHS that were enable us to do that. But clearly we've got a lot of waste and generate a lot of waste, and that comes through some of our contracts and stuff. I just wonder if it would be worth just a sort of check and challenge type session, or organising a symposium where key people from the different organisations can come and talk about their initiatives, what we're doing, and maybe what we're struggling with really. So very happy to help facilitate that from a London North West perspective, because it is something that's top of our agenda. I'm sure we don't always get it right, or we may not necessarily know all the right things, but there also might be some, if we thought differently, some enabling contracts that, like we do recycling in the hospital, and somebody comes, we've got old boxes all over the place that the people put things in, and somebody comes and picks it up. Now there might be different ways of contracting for that sort of thing going forward, if we were sort of pooling our demands in Harrow for that sort of thing. But I don't know the answers. I just think it'd be useful to organise some kind of check and challenge session, really.
Yeah, thank you very much. Yeah, I mean, perhaps if I work with Seb and I get a list of the key organisations and we can contact you all, and you can put us in touch with either yourselves or whoever is leading this work. We could definitely have a good sort of deep dive, I think, into those issues. Yeah.
Thank you, Chair. Yeah, I think that a check and challenge session would be really useful. And I was always trying to link back to our first agenda item and Jackie, some of CLCH's challenges around workforce. And actually these things are interlinked, aren't they? So particularly international recruitment, you will have nurses come over who don't drive, maybe nervous about using a bicycle in a London borough. But actually if we start to link a strategy around Harrow being cycling friendly, safe, you might be able to start looking at some of your workforce challenges as well and promoting Harrow as a borough to work in slightly differently. So I think if we can look at all of those sort of issues that are collective challenges and solutions, it could be a really useful session.
Okay. So Chris.
Just going to ask a question as a citizen rather than to do
Sure,
safeguarding. Your planning department has a big impact on whether or not, if you've got a listed building, you live in a conservation area, or your house is too close to another house, whether you can install any of this stuff. And I mean, the rumours are, or the narrative is, that whilst on the one hand, government and people like your good folk are promoting green energy installations, planning departments and conservation departments are closing it down. I'm sure that isn't happening here, but are you working with the planning department to make sure they don't don't cut off at the pass those things which are good things to do?
Yes, I think there's a slow process of enlightenment around this. I mean, it's obviously a balance from their perspective. They've got to protect the historic environment as well. But the short answer is yes. I have come across this myself at Harrow Arts Centre, which is that picture I showed you. We weren't allowed to put solar panels on not on the main building, but on a building that faced the main building. And I had a fairly sort of passionate discussion around that, because I thought, well, actually, this is around actually demonstrating you're doing something in a really important public building. So yes, I mean, a local plan is being reviewed at the moment. You may well get a presentation on that at some point over the next couple of years. And I've definitely said we need some very clear guidance for householders about if they live in a conservation area or they've got a listed building, about how they can do it in an enabling way, rather than you're not going to get any panels on this. Now, that's obviously a planning decision ultimately, but I think there are many sympathetic examples now of solar panels and heat pumps and everything else being installed in conservation buildings, and we just need to sort of think creatively about how we do that.
I mean, I think the real challenge is in conservation areas where I know, because there's some in my ward, where people want to put insulation in, but they're not allowed to change their windows, or if they do, have got special windows, and there's loads of issues like that. I'm not sure we can really change that, but what we can do is invest in the local plan, make sure that it is helpful and makes it easier for people to do these right things. I think the challenge is listed buildings and conservation areas where obviously you're trying to preserve a certain look, and putting either one windows or solar panels or wind turbines or whatever you want to put there doesn't really match the thing that you're trying to preserve. So it's like all these things, a bit of a balance. But I think conservation areas obviously kind of lean towards one thing, but in the rest of the bow, I think there's much more opportunity. As Matthew said, the local plan is kind of being worked on. It's a massive process to adopt a new local plan. I think it takes at least 2 or 3 years. It has to have a public inspection process and increase. So we've got some opportunities to look at that. And I think probably a presentation here will be helpful, not least because it will include sections on health provision and other things across the bar, because that's all part of the local plan. So that's good. Any other questions? No. Okay. So on page 27, we requested to note the work that's underway and endorse the approach. I think what we've learned here is that actually a lot of partners are very keen to engage with us. So the various officers will make sure that they follow that up. I think for me, it's very key that when we do these things, we do it at a bar level rather than just a council level. Get partners much more involved. So I think we can then do much more and get much greater economies of scale than some of the things that we can do. So I think that's really helpful. So thanks everyone for that. Okay, we now move on to item 9, which is the impact of industrial action on the elective waiting list at Northwest London University. Who's going to do that?
Okay, thanks very much. But before we get into that, I just wanted to share some really good news for the trust with you. Really, yesterday in the HSJ Health Service Journal, they focused on the 2022 inpatient survey, and they highlighted the fact that there was only one trust in the country where it had significantly improved its rating, and that was London Northwest University Hospital Trust. So our score had gone up from 7.8 to 8.3, and that put us that in terms of general and acute trust in the country, there's only 14 ahead of us now. So significant improvement in terms of patient feedback across the trust, and also we've seen significant improvements in our maternity services feedback as well. So we'll get you more detail, but that's hot off the press and highlights I just wanted to share with the committee, because I think for us that alongside our own staff, high net promoter score in terms of are you proud of the organisation and the quality of services provided. That patient experience one is one of the most important indicators for us. So for it to move that scale since the last survey in 2021, we're really pleased with that. So just thought I'd share that with you. But in terms of what we're here predominantly to talk about, can I introduce Anne Joshi, who is one of our Deputy Chief Operating Officers in the Trust and leads really on the elective activity side and planned care side of things. So, Ange, over to you.
Thanks, Simon. Hi, everyone. Pleased to be here. I think we submitted some slides and I'm happy to share them, although I can't share. I think it says only the meeting organizer can. So I don't know if anybody did want to put them up on screen or whether people have them in front of them, in which case I can just talk through the slides.
I don't know if anyone's got a copy to do it, but I think we've got the slides.
Yeah, okay. Fine. All right then. So I'll just I'll take you through the slides and then take any questions. So on the first slide there, what you have is basically just something setting out the industrial action so far, and I know there's been different sets of industrial action that's been taking place, but we've obviously been impacted significantly by the BMA strike, so that's what the focus has been on here. So we've had 5 sets of junior doctor strikes so far and 2 consultant strikes. And as you can see, there's a further 2 consultant strikes planned across September and also some strikes in October. Just a little bit around the governance. So during each strike, the organisation have pulled together a gold command type approach, similar to what we set up during the COVID pandemic, and ensuring we've got a command and control. And leading up to each strike, we would have regular meetings to view the staff rotas, making sure that we plan them in a way that we can schedule as much activity as possible, but whilst making sure that the clinical safety hasn't been compromised. And then throughout the strikes, we had daily checkpoint huddles, staffing safety checks as well, just to ensure there wasn't anything that needed changing whilst we were in the strikes. In terms of prioritising our...
You can now, if you like, share, you should be able to do your presentation. You've now been given
permission. Oh, perfect. Thank you. I'll just do that. Okay. Hopefully you can see the slides.
Yeah, it's there, Ange.
Yep. Okay. Just, I've lost you. Give me 1 second. Sorry, it doesn't like it when I do a slideshow. All right, so the slide that should be in front of you is the prioritising of capacity slide. Is that what you can see?
Yes.
Yep. Okay. So what we did was, in terms of trying to prioritise our capacity, we followed the kind of factors that you can see here. So always starting with clinical urgency, and then looking at the patients that are on a cancer treatment pathway, then trying to consider those patients who have already waited more than 52 weeks on a referral to treatment pathway. And then if there was still any capacity within the rotas left to allow it, looking at activities we could continue to run without affecting the workforce required to support the wards. And that's the way we approached our elective activities that could continue to run. This slide basically just sets out a bit of detail around the impact on the actual planned activity. So you can see here there's the volumes of outpatient cancellations, elective inpatient operations and day cases that needed to be cancelled. But what I think is quite important to note is, when we had the initial strikes, our day case activity was reduced by about 28%, and our elective cases, so this is inpatient activity, by about 43%. We saw quite a large impact during the Easter bank holiday week, and that's partly because of the strikes, but also factoring in the bank holidays, etc. It meant we saw the largest impact on our activity. But then the next set of strikes we had after that, we saw a lower impact, and what we found was we were having more doctors coming to work and remaining on the rota, which meant the activity reductions were less. And then this just sets out the outpatient activity reductions in the same way as above. I think in terms of our planned waiting list, so this slide is basically setting out the impact on the actual elective waiting list. So 77% of the cancellations had been for patients that had been waiting less than 52 weeks. 5% of the cancellations were for patients waiting over 52 weeks, and 1.5 was 65. And I think we had one patient that, for example, on average, that was cancelled waiting for more than 78 weeks. I think it's just worth noting that from the outpatient cancellations, 15% of those were on an urgent 2-week wait pathway. We have obviously got, we had a process in place after every strike around ensuring we rebooked the activity. Patients didn't go to the bottom of the piles. They were back on the waiting times that they were at, and they were prioritised again, initially through clinical urgency and then through the waiting times. And we have our recovery delivery group where we monitored that to ensure that those patients were all rebooked. I think in terms of just looking at the impact on our waiting list size, so obviously as we would expect, the strikes have had an impact on our waiting times for our patients, but we've tried to prioritise it as much as we could on urgency and cancer, and we've managed to keep the PTL pretty stable throughout that time, and we continue to work on reducing our longest waiting patients over 78 weeks. We obviously have more strikes planned and coming up, and this is the approach we will continue to take to ensure that we can keep on top of the waiting times for our patients and keep prioritising those. So that's pretty much the slide pack, and happy to take any questions from people.
Thank you. Does anyone have any questions? No. Okay.
If I could make a comment, so it is worth saying that inevitably some patients will have been cancelled more than once as a consequence of the sequence of striking. Again, we do try and prioritise those where, triple prioritise them, for want of a better phrase, in terms of trying to make sure that we can bring them back in as soon as possible. Inevitably, we have had a series of complaints from people because of their frustrations, especially where some people have waited a long time. We clearly are continuing to drive down our 78-week waiters, but by comparison, in terms of London, the amount of activity that we've been able to maintain, and to be fair, most of the trusts in North West London have fared pretty well by comparison with other trusts in terms of North West London, because of the rigour around the cancellation process, the rebooking. And one of the things that we always were targeting in London North West, some of you may or may not know that we went live with our new Cerner electronic patient record system 2 weeks ago. And as part of that, we were always expecting some downtime as we implemented the new system and planning to go at a bit of a, recognising that staff would take a bit of time to become familiar with the new system. We were having a hard drive. We'd always planned a hard drive in the 5 months before the Cerner go live to try and increase our volumes of activity as best as we could. So we were always trying to do as much activity in that sort of 5-month period anyway, which has stood us in pretty good stead, really, by comparison with some others in terms of to try and maintain our volumes. But equally, we have been pressured by the emergency pathway. The strikes clearly do not help, and it does take us time to recover each time after the set of strikes. And that slide where it indicated the 2 days of consultant strikes next week, and now the junior doctors are reballoted, and they are now also striking for 4 days over that period as well. So this will be next week will be the first time where we have a day where a strike overlaps between the junior doctors and the consultants. So that's even more challenging. But clearly we have a strong process in place in terms of working with our teams around the rotas, and trying to maintain a safe care. But in those circumstances, our absolute focus is the emergency pathway. We have to keep the emergency pathway safe in terms of admitting critically unwell patients into beds and ensuring that we've got beds and the right staff and the right environment for them. So it's not a great story, but we are doing all we can to maintain a safe service for patients that we serve.
Okay, thank you, Simon. I'll see hands going up. So whilst note the report, we note that. Item 10, better care fund submission. Who's going to do that instead? Rachel, Joe.
So I think we're going to start with Hugh, who's going to start on this item. I think it's fair to say that we discussed this at length on the 23rd of June, the last meeting of the Health and Wellbeing Board. There was a further discussion at the joint at the Harrow joint J&B meeting last week, and I think this is an update just to say basically where we are now and what the way is forward. So Hugh, do you want to just outline the submission?
Thanks, Joe. Thank you, Chair. BCF Better Care Fund submission basically draws together details of funding streams and actions that we take locally to achieve the goals of the BCF, which are to prevent admission, to facilitate discharge from hospital and to maintain people's independence in the community. This year the BCF is notionally for 2 years, 23-24, the current financial year, and 24-25. As Joe said, we provided an update in July, which was that the BCF submission had been agreed locally, but was at that time with NHS London. The NHS London appraisers have just come back to say that they've signed off the submission, so it will now go to the national group for formal sign-off. But we would not, it seems unlikely that there will be any significant changes now. The paper that you've received contains details of the financial flows relating to the BCF. They total about 29.7 million in the current year and 31.5 million probably next year. They basically cover a number of areas: NHS spend in the borough aimed at those objectives, an NHS minimum contribution to the local authority, some grants, the Disabled Facilities Grant, the Improved BCF Grant from NHSE to the local authority, and 2 strands of discharge funding, one that the LA receives from NHSE and one that the ICB distributes in the current financial year to the local authority. Although it's not confirmed, that it is likely that we'll have to provide an update for next financial year, although we've planned for 2. As I said, we don't expect there to be any further changes, and the question then is whether the Health and Wellbeing Board is able to sign off the submission. Happy to take any questions anyone has about the detail of the finances, but I wasn't proposing to go through them table by table.
Okay, I can't see any questions. No one else is. So we just on this. Have we made the final submission, or did we delegated to the consultation? Because I thought we made a submission.
Yeah. We have made the submission.
Yes, so the submission has been done through the NHS England, the regional team. They have come back and they did come back with some clarification questions with the council colleagues and my team worked on, and they have subsequently come back and said they're really happy with our responses and we don't anticipate with the comments or queries from us. So yes, the plan has been submitted. I think there's a formal requirement that the Health and Wellbeing Board signs off the BCF plan, hence it's coming here for a retrospective sign.
Okay, but that's not what the recommendation says, though.
No, I think, apologies for that, when we drafted it, we weren't quite sure where we were going to be in case we had some more comments that we needed to address. So that's what, but apologies, the recommendation is slightly outdated.
So yeah, so the last time we discussed this at Health and Wellbeing Board, that was you gave the delegation to me to sign off things I did.
Yeah.
But can we change recommendation 2 then to approve the submission?
Yeah.
Is that everyone happy with that? Is everyone happy to approve the submission? Is that approved? And to finally bring this process to an end. Let's hope next year is a bit more smooth than this year was. Okay, so that will be. Okay, item 11 is the white care, white person model, something very uncontroversial to end the meeting. Do we have Tony? You have to do it. Tony, welcome.
Yes, hello everybody, and thanks very much for the invite. Sorry that I can't be there in person, but I have a number of other commitments today. So just in terms of an introduction, I'm Tony Bellis and I'm a Detective Superintendent for North West BCU. So I cover Barnet, Brent and Harrow, and broadly my responsibilities are for domestic abuse, rape and serious sexual offending and child abuse. And I'm here to speak to you about right care and right person today. So I've been in the Met for a good 22 years. I've worked across various different departments, and a majority of which has been spent within North West, including quite a lot of time at Harrow myself. And just on a personal level, I was born at Northwick Park, so I'm Harrow born and bred, and very happy to be here today. Okay, so right care, right person. So it's an operational model that changes the way emergency services respond to calls involving mental health. It was initially developed by Humberside Police, and it's in the process of being rolled out across the United Kingdom as part of ongoing work across police forces, government and health providers. It's due to be rolled out in London on the 31st of October this year, and it's aimed at making sure that the right agency deals with health-related calls instead of police being the first responder. It has been shown in Humberside to improve outcomes, reduce demand on all services, and to make sure that the right care is being delivered by the right person and the right service, as we all have Article 2 responsibilities under the Human Rights Act. So for victims of crime, it means freeing up police time so that officers can deploy to incidents in line with the core purposes of policing. For health patients, it means helping vulnerable patients to access the right care more quickly, and also a policing response to a health issue can often lead vulnerable people feeling criminalised even where no crime has been committed. And for our officers and staff, it will reduce the number of incidents that they're asked to deploy to on behalf of other agencies. And we hope that within our call centres as well, we'll see the demand reduced to some degree. And also for health partners, I know some data from Humberside suggests that the demand on health partners didn't increase, and in fact it allowed them to review processes and deploy to incidents quicker as well. There has been some reporting within the media that suggests the police won't deploy to any mental health calls, which is simply not right. We will still deploy to incidents where a police presence is required, so when there is a real and immediate threat to life or a risk of serious injury, or when health workers are dealing with violent patients, or when we suspect a crime has been committed. And in such instances as that, we should consider the policing response as normal. So this has been signed off by Directorate of Legal Services, who are the solicitors for the Metropolitan Police. And just to add some anecdotal accounts, so I was a duty officer, a response team duty officer in Harrow back in 2016. And it wasn't uncommon for me to come on to a shift, either a night duty or a late turn starting at 2 p.m, and to have no officers available to deploy to 999 calls from the very start of our shifts. And that may have been officers with 136 patients in hospital, waiting for the handover, officers dealing with missing persons, and a number of other reasons. But it wasn't uncommon to be in that situation, and this is what the right care, right person seeks to address, because you don't want to be worrying about who's going to turn out to the next 999 call as a duty officer, certainly. So I just want to highlight really what the core purposes of policing is within the UK. So the first principle is about prevention and detection of crime. The second is in relation to keeping the King's peace. And the third is to protect life and property. So there's four elements or four strands to the right care, right person that are being addressed. And I'll outline them first and then just deliver them in a bit more detail. So the first is about concern for welfare. The second is about walk out of healthcare facilities or absence without leave from mental health establishments. The third is about transportation. And the fourth is around Section 136 and voluntary patients. So in terms of, I'm going to pause there for a moment and just see if there's anything I've missed, or if anything anybody wants to raise before I go into a bit more detail.
Can't see anything.
Okay. Thank you. So we'll start with the concern for welfare. And the first objective for Right Care, Right Person is to ensure that partners within health and social care conduct their own welfare checks rather than relying on police. So welfare checks should be conducted by the agency who already owns the legal duty of care. This ensures the public is seen by the service they're engaged with and continuity is maintained. And we hope that that will lead to a better service for the public. So the second principle around absent without leave and walk out of healthcare facilities. So absent without leave mental health patients should not be reported routinely as missing to the police. So partners have a legal duty as well as police to locate and return absent without leave patients, and police will support, but only if there is an immediate risk to the patient or to other people. Objective 3 is police should not routinely be called to locate patients who leave unexpectedly from emergency departments of acute hospitals, unless they are deemed to be an immediate threat to themselves or others. And this is the ethos that people are entitled to make their own decisions about whether to remain in accident and emergency departments, and not to expect a police officer knocking at their door perhaps at 2 in the morning to take them back. Fourth objective is around transportation. And transportation for physical and mental health patients will not be carried out by the police unless in exceptional circumstances. So this process ensures that, again, the right care is given to individuals. We know that the use of police vehicles adds to the criminalisation of patients and can add to their stress and discomfort. And the fifth objective is around section 136 and voluntary mental health patients. So police handovers at mental health crisis suites should be conducted within an hour. I know certainly anecdotally and across the Met from the work that's been done, it can take 8, 12 hours and upwards. And the aim should be for all handovers to take place within 1 hour, and police should only be expected to stay with the patient in exceptional circumstances, for example, where the patient is violent. So before I pause again, I just want to go over some figures. So if we look at all those 4 key areas and the key strands that I've just mentioned, there were circa 420,000 calls for service in the rolling 12 months up to June 23. And that resulted in 254,000 police deployments, which is 60% of the calls being attended. And then when we look at transportation of 136 patients, 58% of the time these patients are transported in a police vehicle, which is 3,900 instances. So again, I'm going to pause there. I think in summary, it's 31st of October, which is an ambitious deadline, but I know the Commissioner is very keen to get this right by that date, and I'm going to stop there. So thank you.
Thank you very much, Chair, and thank you very much for that presentation, Tony. One of the questions that I have is regarding the time that this operation is going to be rolled out over. You mentioned the date of 31st of October, but noting from the Humberside model, it took over 2 years, or just about 2 years, to embed the whole process. Now, what assurances can you give us that all the agencies, partner agencies, are prepared for this change in the way they're going to be working, and how is that going to be, followed up? So I'm a little bit concerned about the short time frame that we're going to be doing this changeover. So I was wondering if you can comment on that, how the other partners are prepared for this and what can be done further.
Yeah, certainly. So this is a consultation process that's a national one. So locally, this is being led by Matt Twist, who is our Deputy Assistant Commissioner. And within that consultation process, there's adult, children, LAS, Mental Health Trust and ICB stakeholders present at all of these meetings. And they haven't just been going on for the last couple of months. This has been a process that's been ongoing now for some time. There's every organisation has representation, and quite largely there's already existing policies in place around a number of these key themes, but there are additional pan-London processes being developed at that very top executive level. There's 4 work streams, I believe, around communications, data, policy and training. And what I'd say, and what I've been told by Scotland Yard and the centre, is that every organisation needs to be following the directions from their seniors as to their approach to right care, right person. So they're the assurances that I can give you at the moment. This isn't just something that was sort of dreamt up on the Sunday and rolled out on the Monday. This has been in consultation now for some significant time with executive stakeholders from all agencies.
Thank you.
Is there any other questions?
Hi.
Sorry, just before you welcome, I don't think I introduced you properly at the beginning. Welcome to the first meeting as Director of Children's Services. Welcome back to Harrow.
Thank you very much. It's always wise not to say too much at your first meeting, but I think, there's a lot of national coverage, and we all absolutely appreciate the challenges for the police. And I'm from a children's services background, and you have my sympathy. But I suppose what would be helpful for us is to know what will be the potential impact for us in Harrow. And there is a lot of national coverage in terms of, and we can understand the rationale and get the statistics and the data. So it'd be helpful really in terms of preparing and looking at what will this mean for us, and how do we as a partnership work together to ensure we get the right outcomes for our community.
Okay, so I think that this is due to this being a pan-London model. We shouldn't be trying to deviate from that with any local practices. I sit on a number of forums and have presented this. I'm really proud of sort of the great relationships that we have with children and adult services. But yeah, was there a sort of specific point you wanted me to address?
No, I think maybe it was a conversation offline, but it was just really helpful. And I suppose maybe over time, post-October, we might have specific examples that looking at the learning and looking at what we need to do differently. So it's probably a little unfair question. At this point, you might not be able to predict what the impact will be on us as a partnership. But it was really just thinking about out of hours, thinking about what do we, if anything, do we need to do differently? I absolutely understand what will happen in practice, but there will be consequences, won't they, arising from this guideline?
Yeah, so I think that these policies will be discussed at that executive level with the London-wide or even national processes and policies disseminated out locally. But one thing that we can certainly look at, and it may be a standing item for, I don't know, Children's Board, Adults Board, or any other board, is to look at those escalation processes, perhaps where it hasn't worked, and look at those case studies locally. So albeit the policy will be a wide one, local delivery and escalation processes is something we can look at.
Okay, thank you.
Thank you. I've got Simon next, then Pritesh.
Yeah, hi Tony. Simon Crawford, Deputy Chief Executive of London North West Healthcare Trust. So I suppose my concern is not the principles necessary about not routinely having to locate the AWOLs and wanting a smarter and quicker handover, but clearly from within our A&E department, in particular in terms of handovers in that environment, it depends on the type of presentation, but clearly some can be quite intimidating, quite violent, quite aggressive, and we aren't necessarily in the first instance geared up in an emergency acute department to handle that type of presentation. And also it can I know we do have security staff, and we do have some RMNs, but not enough for the volume of presentations that we have. But equally, as you're probably aware, we could end up with between, any one morning we'll come in between on the Northwick Park site between about 4 and 12 different mental health patients. So our ability to look after them safely, and it's not just about looking after them, it's recognising the acutely unwell patients still in the department, where our staff's focus is to try and support them in terms of threat to their own life. So it's the application of it, I think, is what I'm concerned about, is that, you know, we need to think about a transition period and what the definition of the criteria is in terms of whether there's an absolute drop and go, or whether there is a different approach. And then equally applies then to the AWOLs that you know, certainly we're not geared up to be looking for patients once they abscond and leave the department. So we certainly wouldn't be doing that. So I draw a distinction between a patient going AWOL from being an inpatient in a mental health facility, as opposed to the patient going AWOL and is recognised as a risk to themselves and the patient from an acute hospital environment into the emergency department, because we would not be looking to go chasing them down. We're not geared up, not resourced to do that. Haven't got necessarily the knowledge base, the relationship with the patient to understand where they might go and track them down, etc. So our default would be we would still expect the police in those circumstances to support.
Okay, so just to address a couple of those points, Simon, thanks for that. So on the section 136, certainly within the Met, we are looking to reduce the number of 136s that are conducted by officers, and whether there's any other mechanisms or any other pathways that we can take. One, I think we piloted already, has been locally getting an inspector's authority, or I say authority, at least discussing it with the inspector prior to execution of that power. And we've already seen a reduction in that demand. So that may be something with the right care, right person. It will be a culture change over time, and hopefully we'll see some demand in that, because it does have to be proportionate, and it's a very, you know, it's a very restrictive measure to take, and there may be other options. Secondly, just around the absent without leave patients and violence. So obviously, if there's a real and immediate threat to life, risk of serious injury, or healthcare workers are dealing with violent patients, we will always deploy. And we will always be there. It's the routine cases that we've all seen where, you know, you may get somebody who's absent without leave, reported as a missing person, officers conduct their inquiries over X amount of hours and locate them, perhaps 136 them, take them back in, and then round we go again. So it's those sort of situations, and the police aren't geared up for it either, for those sort of health-related challenges. You know, the vacancies that are held, the junior workforce, and the other demand that we see is exactly why this is being brought in. But just to reiterate, wherever there is a real and immediate threat to life, risk of serious injury, colleagues in danger, violent patients, yes, we will be there.
Okay, thank you.
Hi, and thanks, leader. Hi, Tony. I'm Hitesh Karia, Portfolio Head of Children's Services. Thanks for the presentation. It's really useful. My leading on from Pramjit's sort of point, really, what my concern is about the transitional arrangements and trying to seek reassurance from you in terms of your resource allocation for allowing the transition. So some of this seems to be fairly definitive in terms of, as you quite rightly said, absent without leave, and you know, not reporting that through, and unless there's a concern that that's leading to immediate danger. Same with section 36 in terms of the transition. I think you partly addressed that, but it's really getting reassurance from you in terms of our local aspects and having the resources for a transition. As my colleague has mentioned about Humberside, in terms of the kind of full transition has taken over 2 years to make it sort of work. And obviously we in the children's services, we have an integration agenda, and I think there's lots of partners who are, you know, working collaboratively. But again, I see the fulcrum kind of coming back to, whilst I understand the need to reassess that based on what you just said in terms of shortage of your own resources, but I just want to get some reassurance locally to make sure that we have adequate time for communication specifically, and how this sort of transitional arrangements works to get to where the plan is. And from your perspective, there is a local, I expect the pan-London element, I understand that, but there is some reassurance from a local perspective that we have resources that will allow for a smooth transition and making sure that this kind of works over a period of, you know, a few months as opposed to the October deadline.
So there will be a triage process in place which I've yet to see, which will be for the initial call handling, and that will triage the calls. I mean, in terms of resource allocation, clearly the Metropolitan Police don't have the resources to or the capacity to conduct all of this work that we have picked up. I mean, in terms of other partner agencies, it may be that health are best placed to talk about their own levels of resourcing in terms of that demand. And these are conversations perhaps that should be having with senior leaders within those agencies. Because I mean, I don't know that the sort of the resources and the challenges you may be facing.
No, I appreciate that. I'm not sure who's controlling the work streams in that sense as well. But again, my only concern is that it seems like a very tight transition period, and obviously that can have ramifications if you know, subjective decisions are made around absent without leave, and that can lead to unnecessary.
So yeah, I mean, these should be objective decisions made based on the policy and the triage process that's being rolled out across our call centres as well. So I think, you know, it's going to be along the lines of, is there an immediate threat to life or a risk of serious injury? Has a crime been committed? Is there violence or risk of injury or harm to other people? And if the answer is no, then that's what the triage process is looking to understand. It's that real and immediate risk and the crime, just to get back to those core policing responsibilities. So I can't really comment on sort of resourcing and demand within the other agencies. And this is something that, you know, executive level stakeholders across London are having the conversations at that level.
I appreciate that. No, thank you. My focus is actually more just around your own side, because obviously there'll be, on a long-term basis or a medium-term basis, there will be a reduction in the resource that you allocate quite legitimately, because obviously if I just look at the percentage in terms of what those calls are, from the 450,000 calls, you know, 60% are managing serious. So there's a clear need to reassess that. But it's whether in the short term there is still a kind of overlap to allow for these miscommunications that could arise, or, you know, the kind of partner agencies to conform to what's being proposed as well. That was really the intention, not from other resources, but from your own perspective.
I mean, all I can say, it's going to be along those key principles that I've talked about, and the date is the 31st of October. I mean, this isn't a new issue. HMI CFRS did conduct a report in 2018 highlighting a lot of these challenges, but we haven't seen a lot of change since then. So, you know, this isn't something that has just appeared, and I think it's been a long time coming, really. I've certainly seen a slow sort of mission creep over the years towards attendance at certain calls. But I mean, it's difficult for me to sort of add any further comment to that, really. You know, I'm going to work with all of our partners that I do already. We have a really good relationship, and if we've got any concerns after this is in place, then we can raise them, feed them in centrally, but also any local issues we can discuss and have that escalation process in place.
Really appreciate that. Thanks, Tony.
Well, John, then Lisa, then Chris.
Just really from a local resident point of view, it doesn't sound like there will be a local cross-partnership way of monitoring how this plays out. So my question really is would this be the place that happens, or is there another place? In terms of the figures that we were quoted were all national figures, and certainly the protocols have been developed London-wide, but in terms of the impact locally and or identifying issues that then need to be resolved, it doesn't, from what you've said so far, it doesn't sound like there's a place where that will happen. So my question is, where should that place be, really?
I mean, I think there's probably a role for us on the strategic level, but I think operationally it's probably a good idea for, as this is implemented, for officers and the police to meet on a fairly regular basis, at least from when this starts, just to pick up any of these kind of issues, unintended consequences, or that kind of thing. So I don't know if that can be sort of scheduled in either weekly or something, meetings with officers and police, just to kind of pick up on those kind of issues, and then maybe report back here to the next Health and Wellbeing Board, and we can then decide. Is the next one after the 31st of October? So the next one after the 31st of October, so that we can then pick up on a strategic level any issues. But operationally, I think that's something that might need to be addressed much more quickly if there are issues or concerns. I mean, I totally understand the desire for police to do this and the operational need to do this. It's just making sure it's done in a safe way that doesn't, affect our staff or the people that we care for. So, just my point of view, it's really key that we have that kind of regular contact, especially given it's implementing fairly quickly, to pick up within the first few weeks of it, just to see where the issues are. We've got Lisa.
Yes, I'm really happy to respond to that. I know we've had a couple of conversations within our local health and care executive about this, but this has felt to me like one of those tricky areas where it's actually sort of been elevated to that London level and managed there. And I think as Tony's reflected, it's very much been looking at that London pathway. I know CNWL as our mental health provider are in weekly contact with your colleagues, Tony, to plan for this. But actually, it feels to me now is the time to probably be more proactive about a local partnership and assurance piece, probably in the first instance, around where, what have we mitigated, where are there still risks, and what do we need to do, and then think about the monitoring going forward. So really happy to support trying to get that established through our local partnership.
And just to add to partners, the police commissioner has been very good at coming to London Council's leaders meetings. So if there are any issues that need to be raised at a London-wide or that kind of level, people just let me know that I can ask the question here when it comes to London Council. So I think he's now scheduled to do that a few times a year, so we get that opportunity to ask him, which I don't think previous commissioners have done. So it's, to me, very welcome that he's done that. I think that's really important going forward. Okay, Chris.
Yeah, I'm just going to. Lisa sort of said what I was going to say, really, which is that, I would have thought at a local level, what we've got to do is work out what the transfer of work from the police to local agencies means, and what, assuming the police weren't wasting their time, this work is now going to be done by somebody else. And so you've actually got to count it, name it, and then work out what it's going to cost and who's going to do it. And one would expect there to be a local working group working on that to actually deliver, to keep people safe, really. So that's sort of picked up what Lisa was saying.
Thanks. Simon, do you want to go and get any?
Yeah, and I'm fishing in the same pool, really. I absolutely welcome. We probably do need a joint session with CNWL, because by and large, most of the impact will be upon them and their services. So we need to understand how they're going to be able to respond and what they see as the risks. And I dare say, Lisa, it's probably one of these. Northwick Park serves Brent and Harrow in equal proportions. Really, it'd be probably helpful to have a joint discussion between appropriate borough representatives and CNWL.
Tony, do you want to come back with any of that?
I just wanted to highlight that the reason this is being brought in is because the well-being of our communities is absolutely number one, and we want to ensure the safety of our residents. We can't have situations where officers can't deploy to 999 calls where people are in absolute need for crime matters because they're dealing with these other issues, and that is something I'm really passionate about. A lot of the conversations are happening at that executive level, and there is a communications work stream that should be feeding into each agency as well. So we've got one in the Metropolitan Police who I'm engaged with, and I don't know who they are within the other agencies, but it's certainly useful to identify who they are and perhaps try and obtain some more information about the impact it means for you. So yeah, that's everything from me, really. It's a challenging time, and there will be a lot of data and a lot of scrutiny when this does come in, I'm sure, from each agency. But I'm absolutely committed to those conversations with the local partners, as we do already, around those escalation issues and to highlight any challenges that we do face when it does land. That's it from me, Simon. Thank you.
Thanks, Tony. I mean, obviously there's a London-wide element to this, but my experience of trying to do things at a London-wide level is it's very difficult to deal at that level. I mean, there's obviously 32 boroughs, there's however many BCUs, you've got a lot of people involved in that. I mean, even just when it came to the Better Care Fund and doing a North West London approach, the logistics of doing that with all the different councils and health wellbeing boards was a bit difficult. I think it would be really helpful if we have something especially in the first few weeks at a local operational level. So we can try and raise issues, either with you or whoever you want to put in to do that. And that's the appropriate thing. I think from the partner's point of view, I think we'd be keen to do that. As I said, we totally understand the demands on the police and want to make sure that you are able to respond to 999 calls effectively and do all the rest of it. But equally, this is a big change potentially, and we're just slightly nervous about, especially as it begins, any of the operational impacts. Obviously, as people get used to it, then I think we will get used to it and be able to deal with it. But in the initial stages, I think it's really important that those contacts happen frequently.
Yeah, so I think subsequent to the process starting, like I said, it's important to capture those local issues and local challenges. But prior to that, it's such a complex area. There's 32 local authorities, there's 12 BCUs, and like I said, count however many ICBs. What we don't want as well is 32 different ways of doing it, and that's why certainly from the centre we're being told, don't make any local arrangements that would deviate from the organisational or corporate policies. But in terms of the escalation process and looking at how it's working locally, that's certainly something I'd be supportive of.
Okay, so just as a way forward, I'm told our next meeting is on the 2nd of November, which is conveniently a few days after this has started. Maybe we can have a paper or something on how we can make sure we feed properly into the escalation process, and also whatever local things we put in place and who sits on that. That might just be a helpful thing, because as I said, we're all happy to, I'm certainly happy to support what you're trying to do. It's just the timeline of it and making sure that there aren't any short-term issues that pop up that maybe didn't get picked up in Humberside but might happen in London. I mean, as you say, it's very complicated. We don't have a hospital in Harrow. Our hospital is just across the border in Brent. So, there are differences that we have with other boroughs in terms of that. There's just going to be different needs. I mean, London is different. All 32 boroughs are different. There's no uniformity in London. That's why sometimes you might need things, but I understand you need to go through your operational processes as well. So, okay, are people happy with the paper coming back on the 2nd of November on this, and maybe some suggestions, preferably discussed and agreed with the police in advance of the meeting, so we can be clear what can be done and what can't be done, but just to kind of put in place some things. Because obviously the last thing we want to happen is something very serious, have a serious incident, which would obviously be devastating for the people involved, but also this whole process as well. So it's really important we get it right. Okay. So for us to note the updates, we will note the updates. I don't have any other business, so I declare the meeting closed. Thank you very much.
Can I share?
Oh, you showed me this.
Yeah.
It's quite, have you sent this out?
No, so we're going to be sending it out with our annual report.
Yeah.
We've got this is kind of somewhere. We can find the number.
Yeah.
Has had 8 to 10 deaths. These 2, 3